renal clearance is the volume of plasma that's cleared out by your kidneys in a particular given amount of time. And renal clearance is actually used to test the health of your kidneys and a measure of GFR as well. So you can actually use renal clearance to detect things like glomerular damage or follow the progress of someone's kidney disease. So there's an equation for renal clearance. And our equation tells us that renal clearance rate in mils per minute is equal to concentration of a substance in urine times the flow rate of urine formation divided by the same concentration of that substance in plasma, right? So, basically what this is saying is how much of the substance is ending up into your urine as a function of how much urine you're making divided by how much of that substance did you have in your blood to begin with, right? And that tells you how quickly it was cleared out of your body. So an example of renal clearance is where we can use this thing called inulin. Inulin, not insulin, but inulin is a plant sugar. It's a plant polysaccharide. And this plant polysaccharide, it's a standard used to determine renal clearance. Okay. Now, inulin is only filtered, but it's not reabsorbed or secreted by the kidneys. So inulin's only filtered, which means that if you can actually inject a known amount of inulin into someone's body, and you measure how much inulin ends up in their urine, then that gives you an idea of their glomerular filtration rate. Because inulin's only filtered, it's not secreted, nor is it reabsorbed. It's only filtered. So by measuring how much inulin ends up in urine over time, that tells you directly what your or actually indirectly, what your glomerular filtration rate was, because it's only filtered, not secreted or reabsorbed. And so, inulin clearance should be about 125 mils per minute or so. Yeah.
How is it that like a chem panel, like a chem 8, we get a GFR rate?
Yeah.
How is that possible because we're just using serum?
I know, we'll get there actually. That is interesting. I know. It's based on standard curves. And what they're measuring there, if you're looking at someone's bloodstream, not their urine, to determine GFR, what you can look for is things like blood urea nitrogen or creatinine. And the concentration of those molecules should be, at a certain concentration in your bloodstream. And if they're too high, that suggests that your GFR is slow or low, because then they're not being cleared out by your kidneys. Or if those molecules in your bloodstream are too low, that suggests your GFR is fast. So that concentration is all based on standard curves, which is actually pretty cool. But it's not the best way to measure GFR because there's too many confounding variables, and we'll come back to that. But inulin is a better way to measure GFR because you're injecting a known quantity of this substance in someone's bloodstream, and that you have to wait, maybe 24 hours or so, and then over time measure how much inulin was cleared out by their kidneys, and that gives you indirectly what their GFR is. So it should be 125 mils per minute. So if we can use inulin to determine renal clearance, then we can actually couple that with other substances. So let's say if someone's clearance rate is 0. So let's say that their renal clearance of a substance is 0, where C is equal to 0. You find none of this substance in their urine, because when you divide by the concentration of the substance in the bloodstream, it ends up coming out to 0. So what if their clearance is 0? Well, this means it's completely reabsorbed, and or not filtered. Right? If you don't clear a substance at all, it's either totally reabsorbed, like glucose, its clearance should normally be 0, or it's not filtered. Like if you think about some things that aren't filtered, large proteins, cells, those should have a clearance rate of 0. Now, what about if your renal clearance is exactly equal to 125 mils per minute? What does that tell you about that substance, the way your kidney treats that substance? Actually, let's put it this way. Like if your clearance is the same as glomerular filtration rate, that means that substance is only filtered. It's not reabsorbed or secreted. That makes sense. And so an example of a substance whose renal clearance rate is the same as GFR is inulin. So inulin would have a clearance rate of 125 mils per minute, which should exactly match GFR because it's not secreted or reabsorbed. But let's say if a substance has a clearance rate that's greater than normal GFR, like if you're finding the substance in higher concentration in the urine than you would due to only filtration, then you would expect then that substance is also secreted, right? So if you get secretion and filtration of a substance, then its clearance is going to be faster than glomerular filtration rate. So an example of a substance that has a clearance rate that's greater than GFR, most drug metabolites, especially something like penicillin. Penicillin actually has a really high renal clearance rate. And so you can actually measure clearance as a function of someone's kidney health, which is actually pretty cool. What about if their clearance is less than 125 mils per minute, but greater than 0?
Reabsorbed.
Yeah, some reabsorption. It might be filtered, maybe slightly secreted, but you probably get some reabsorption there as well, which would mean why it's less than the filtration rate. That's basically what this part's saying, which makes sense. Now, what this shows here, you guys, is just the example of inulin clearance. So if in your bloodstream you have a known quantity of inulin, which then you can get a concentration there, if a particular volume of blood enters your glomerulus, you should expect then that from that particular volume of blood, you could see then that you get the amount of inulin that's being filtered that matches the concentration in your bloodstream, and that over time, because inulin is not reabsorbed, it's only filtered, nor is inulin secreted, that the amount of inulin you find inside your urine will give you an idea of their glomerular filtration rate. So their inulin clearance can tell you about what their GFR is. This is actually a more precise way to measure GFR. And you have 100% inulin excretion because it's totally filtered, not reabsorbed or secreted. An example of a substance that is filtered but also secreted is penicillin, where in your bloodstream penicillin gets filtered because it's small enough, but penicillin is also deliberately secreted from bloodstream into the tubular fluid, which means its clearance is greater than 150 mils per minute. I'm sorry, greater than normal GFR, which is 125 mils per minute, right? So if renal clearance of penicillin is 150 mils per minute, that suggests then that it's also secreted, not only filtered. Okay, and that's an example of penicillin. In fact, penicillin it's handled by your kidneys so well, almost too well, so where if you're taking penicillin, it's cleared out by your kidneys so rapidly you have to take higher doses of penicillin just to exert the same effect because your kidneys secrete it too quickly. In fact, back in the day when there's like penicillin shortages, they would just harvest penicillin from people's urine because, when you take penicillin, it would be cleared out so rapidly that even before it was metabolized, you can actually just have, like biologically active penicillin in its form in urine. And they actually would just extract it from urine, but if your life depended on it, I'd say give me that penicillin urine. Now, in terms of other homeostatic imbalances, you guys, like chronic renal disease is defined as a GFR less than 60 mils per minute for more than 3 months. You can find this examples of things like diabetes or hypertension. Hypertension could decrease GFR because we talked about how, hypertension as a protective mechanism, you find vasoconstriction of the afferent arteriole, which could potentially lead to a decrease in GFR too long. That's chronic. That can lead to chronic renal disease. Or diabetes can also affect the micro and macrovasculature of your kidneys, which can also reduce your glomerular filtration rate. And then renal failure is defined as a GFR less than 15 mils per minute. And this can lead to things like uremia, which can lead to dementia because an excess amount of uric acid can actually start to cause damage to your neurons, causing dementia, as well as ionic and hormonal imbalances, toxic molecule accumulation. And this is reversed or treated with hemodialysis, which is basically like an artificial kidney, or someone gets a transplant. Now, in terms of the normal physical characteristics of urine, we understand that urine should normally be kind of clear. It should be kind of pale to deep yellow from a urochrome pigment. This actually comes from hemoglobin breakdown. But abnormal colors include like pink, brown, or smoky. Certain foods and bile pigments, blood, and drugs can make urine different colors, which can suggest, damage or can be due to food intake. I know in myself, like if I eat a lot of beets, like those beets make my urine more pink, like more red. Doesn't mean I have blood in my urine, but pink urine could suggest blood in the urine. I just know it's from eating a lot of beets. So there's not always cause for concern if urine's a different color. Otherwise, like brown and smoky can be induced by certain drugs too. Now, cloudy urine can indicate urinary tract infection because the bacteria, as they're washed out with urine, those bacteria can kind of give urine a more cloudy appearance, so that may indicate UTI. Normally, the urine should have a slightly aromatic odor, but it can develop a stronger odor due to bacterial infection, or if the bacteria feed on substances in urine, they can produce odors that are more malodorous, right? And but we understand that certain drugs and vegetables can also alter someone's urine smell. So not stinky urine doesn't always mean that they have an infection. They, maybe just had like a huge plate of asparagus for dinner the night before or something. Otherwise, normal pH of urine should be slightly acidic. In fact, it's the acidity of your urine that also protects against infection, because that acidic urine helps to kill off bacteria as it washes out those bacteria from your urinary tract. Now, an acidic diet would be a diet that's rich in protein and wheats, which also reduces your pH, so that you actually excrete a lot of acids through your urine, which is why urine becomes more acidic. Alkaline diet would be more like on the vegetarian-based diet, or from prolonged vomiting, where due to increased alkalinity inside your bloodstream, your kidneys can eliminate more of those excess bases through urine, which also increases the pH of urine. In fact, urine can have a pH as high as 8.0, which is actually fairly basic. Also, urine should have a specific gravity that ranges between 1.001 and 1.00035, and this is going to be a measure of solute concentration. Now, if someone's specific gravity is really high, that suggests they have too many solutes in their urine, and that may indicate infection or trauma. So also, specific gravity should normally fluctuate with changes in blood pressure. If someone has a fixed specific gravity of urine, that indicates kidney disease. Now, normally urine should be mostly water and some solutes, has a lot of wastes. Nitrogenous wastes include things like urea, uric acid, and creatinine. Urea comes from amino acid breakdown, and urea can be used actually as a measure of GFR. So an earlier question was, how can we determine GFR by just taking a sample of someone's blood, right? Well, by taking a sample of blood, you can measure their BUN, or blood urea nitrogen. Typically, this waste should be eliminated by your kidneys. If this waste is in high concentration within your bloodstream, that suggests that your GFR is slow and low, not enough to clear off this waste from your blood. And so we actually can measure the concentration of urea in the bloodstream as a function of GFR. However, it's less reliable because of dietary influences on this urea nitrogen. Because urea is a byproduct of protein metabolism, if someone has a high protein diet, then their blood urea nitrogen will be abnormally high, which means that it doesn't mean that their kidneys are failing. It just might mean that they have a really rich protein diet, which means that their BUN will be elevated, and that could actually give you a false reading on their GFR from that value. Uric acid comes from nucleic acid metabolism, and that's also eliminated by your kidneys. Now, when uric acid accumulates too much in your joints, that's what causes gout. And we'll talk more about this in pathophysiology. Now, creatinine is also a metabolite of muscle, and it comes from creatine phosphate, which is a way that muscle cells can store ATP for later use. But they store it in the form of CP, or creatine phosphate. The metabolite of creatine phosphate is creatinine, and creatinine is actually cleared out by your kidneys as well. This is also a useful measure for GFR. So you might also measure someone's creatinine levels in their bloodstream as a function of GFR. So let's say if someone's glomerular filtration rate were really fast, what would you expect their creatinine levels to look like in their bloodstream? Would their creatinine be high or low if their GFR is fast?
Low.
Creatinine levels should be low in the blood because it's being cleared out by your kidneys really quickly, right? I mean, it'll be high in the urine, but low in the blood because it's being cleared out. So we can measure blood urea nitrogen and creatinine as a function of GFR. Other compositions of urine, well, you can find solutes there, like sodium, potassium, phosphate, sulfate, calcium, magnesium, and bicarbonate, or just bicarbonate ion here. And abnormally high concentrations of any of these constituents can indicate infection or disease. Now, in the last part of this lecture, we're going to talk about the anatomy of the lower urinary tract. And so we'll talk about the ureters, urinary bladder, and urethra. Now, the ureters are these fibromuscular tubes that basically connect from the kidney to the urinary bladder. They originate at the renal pelvis and then exit at the hilum of the kidney, and where they actually go down the posterior lateral walls of the urinary bladder, and they actually drain urine into the bladder at the level of the trigone. Now, the ureters have three main layers. We've got a mucosa, muscularis, and adventitia. The mucosa is basically a transitional epithelium that lines the lumen of your ureter. The muscularis is smooth muscle, whose function is to be involved in peristalsis for transport of that urine. And then adventitia is an outer layer of fibrous tissue that kind of holds it all together. So looking at those three layers here, we can see our mucosa, which lines the lumen here. We got our muscularis, which is in the middle, and then our adventitia on the outside. Now, the transitional epithelium you find in the mucosa, you can see here, the function is for stretchability because the ureters because there's little blebs of urine that get transported down the ureters have to be able to stretch to accommodate those little blebs of urine. So that by having transitional epithelium in there, that'll increase the stretchability. The reason why you have smooth muscle in the ureters is to basically help transport that urine through peristaltic waves of contraction. So it's actually squeezed down from your kidneys towards the urinary bladder. And then the adventitia is just an outer protective layer here. Now, the urinary bladder, its main function is for storage of urine, and it's located just posterior to the pubic symphysis. And in females, the urinary bladder lies anterior and inferior to the uterus and directly anterior to the vagina. And in males, the urinary bladder just lies anterior to the rectum as well as superior to the prostate. Now, the posterior inferior triangular area of the bladder is called the trigone. This is the place where you find the ureteral opening. So the ureters enter the urinary bladder at the trigone. And this is clinically significant because this is at the base of the urinary bladder, and it's a common place for infection to occur because this is where urine kind of settles. And because when urine's more stagnant and it doesn't move a lot, it's more prone to bacterial growth, which can put you at risk for infection. And because it's also near the urethra opening, this is where bacteria might also enter into the urinary bladder. So it's close to a place where bacteria can enter. Now, the urinary bladder has four main layers or tunics. We got a mucosa, submucosa, muscularis, and adventitia. The mucosa of the urinary bladder, it's actually made of transitional epithelium, just like the ureter. And there's also rugae, which allow for distension of the bladder, so that's for some stretch. The submucosa just supports the bladder wall. Muscularis is the detrusor muscle, which is basically 3 layers of smooth muscle, so it's under involuntary control. And then we have an adventitia, which is an outer layer of tissue there. So looking at the anatomy of the urinary bladder here, what we find is we have our trigone here. These are the places where the ureters enter the urinary bladder, and there's basically that's where urine drains in the bladder. And this is the urethra, which is right near the trigone. We find that the 3 layers of the bladder wall. We got our mucosa, which is transitional epithelium on the inside. We got our submucosa and our muscularis, which is smooth muscle, as well as an outer layer of adventitia here. Now, the inside of the urinary bladder has transitional epithelium, which allows for stretch, and this epithelium is stretchable because it's very pillowy and these cells are plump, which allows for the bladder to stretch quite a bit. You can see here the difference between a flattened and a stretched bladder. Here's where this one's flattened. You can see that once it's stretched and full of urine, the urinary bladder can increase in size, 4-fold or more. So it can store a tremendous amount of urine. Now, the urethra is a fibromuscular tube that originates at the neck of the bladder and conducts urine to the exterior of the body. So basically just transmits urine out of the body. Now, the urethra has 2 main sphincters. We've got an internal and external urethral sphincter. The internal urethral sphincter is smooth muscle, so it's under autonomic control. The external urethral sphincter is skeletal muscle. It's under conscious control, which is why you can hold your pee, right? So when you think about, like, if you have to go urinate, luckily we have this external urethral sphincter, which is skeletal muscle, and it's under somatic or conscious motor control. But this takes time to learn how to use, which is why, like infants, they don't know how to hold their pee yet, so that's why they pee themselves. And as you get older, and there's you can see neuromuscular changes as well, the weakening of your muscle as well as deficits in the nervous system. You can see that there's also some incontinence with aging as well. Now, in terms of the urethra, you guys, we got our internal urethral sphincter here, our external urethral sphincter down here. We have the female urethra, which is much shorter than the male urethra. And so the female urethra, it's only several centimeters in length, which is also easier for bacteria to get into the bladder. So you're more likely to see bladder infections in females than males. However, in both females and males, you see that there are antimicrobial secretions inside the urethra. So there's actually mucus glands inside the urethra in both females and males that actually helps protect against infection. These mucus glands secrete bacteriostatic molecules that prevent infection of the urethra, which is nice. Also, what prevents infection is normal voiding or urination. So just actually washing out those bacteria from frequent urination also prevents infection of the urethra. Now, in males, there's 3 main parts of the urethra. We have prostatic, membranous, and spongy urethra. And the very tip of the urethra is called the external urethral orifice, aka pee hole, right? So that's the external urethral orifice out here, right? Males and females. And so in males, we have the prostatic urethra and the prostate. We got the spongy or membranous urethra here in the urogenital diaphragm, and then the penile urethra, which goes along the length of the penis here, also called the spongy urethra. And we'll come into more detail on that next week when we talk about the reproductive system. Now, micturition is called urination or voiding. It involves 3 simultaneous events. For one, you need contraction of the smooth muscle of your bladder, detrusor muscle, which is under autonomic control. 2, you need opening of the internal urethral sphincter and opening of the external urethral sphincter. So it involves autonomic and somatic or conscious systems in order to void or micturate. Now, the way this works, you guys, is that from the autonomic side, what happens is that as the urinary bladder stretches, there are baroreceptors here that can sense that stretch. If there's a lot of stretch, that actually inhibits sympathetic activity, excites parasympathetic activity, which causes the detrusor muscle to start to contract. And if that smooth muscle starts to contract, that can actually promote micturition or voiding, because the smooth muscle of your bladder starts to contract due to stretch. That's a feedback loop that involves your spinal cord. Now, what we also find too, guys, is that from higher brain centers, we see that we have a pontine micturition center, and it promotes micturition by acting on all of these spinal reflex pathways. So we find that by decreased somatic motor nerve activity, you can actually inhibit the external urethral sphincter and then allow for voiding or micturition. And opposite to you guys, to inhibit micturition or voiding, we have the pontine storage center. And this prevents micturition by decreasing sympathetic activity, increasing sympathetic activity, and increasing somatic motor nerve activity. And this is why, like, if you have to urinate really, a lot, this is why you get a sympathetic response. Think about like the times in your life when you've had to pee really badly. You might start to sweat. Maybe your heart races. You get this increased alertness and sense of urgency, right? Well, it's because you're becoming more sympathetically active, and by increasing sympathetic activity, that prevents contraction of your detrusor muscle. Okay. Also, by increasing somatic motor nerve activity, it prevents the external urethral sphincter from relaxing, which also inhibits micturition or voiding. But the key points here, you guys, is that you need 3 main events, right? So you need to have contraction of the detrusor muscle, which is actually mediated by the autonomic nervous system in response to stretch on your bladder. You need relaxation of the internal urethral sphincter and relaxation of the external urethral sphincter in order to void or micturate. And that's basically what this slide is showing here.